My name is Brittany Choate. I'm Director of Programs for Saliva Direct Inc., and it's my pleasure to welcome you to this session of Saliva Direct Inc.'s annual conference. We're thrilled to have presenters, as I said, joining us from around the world, and this session is on increasing diagnostic access through patient-centered programs. I'm pleased to introduce our first speaker. First up is Dr. Indira Martin. She is joining us from the National Reference Lab, Ministry of Health and Wellness in the Bahamas, and her title is on People-Centered Public Health Diagnostics, Oral Fluids for Increased Access. Dr. Martin, over to you.
Yeah, thanks again for the introduction. So just by way of further introduction, I'll say I'm a public health lab director here in the Bahamas. And therefore, this is going to be a very, I guess, pragmatic approach to the topic at hand, saliva sampling and testing. And although I'm from the Bahamas, I definitely feel within my saliva tribe here. So very happy to be here with other persons who are excited about the potential for saliva in testing. This is my conflict of interest. I have no conflicts of interest. I work solely in the public sector. So one of those people. Yeah, so just a little bit about my archipelago, which I love very dearly. It is a beautiful country, especially from space. It's an archipelago of approximately 700 islands and keys, of which 30 are inhabited. We have a centralized health system, meaning that all of the testing labs, the major testing labs, are located in Nassau. So all of these islands have to send their samples to Nassau for testing. And as you can imagine, this can present some issues in terms of logistics, which can affect access to testing, especially for persons in some of the lesser inhabited islands. One of the great Caribbean philosophers, Edouard Glissant, has said that the world is an archipelago. So I note that a lot of the challenges that we have in the Bahamas can be extrapolated to the wider global context in terms of access, and in particular in terms of ensuring equity of health access over disparate space. So this is the major challenge of my country, the Bahamas, because we do have this disparity. And just further along this line, I'll tell you a little story about during the COVID pandemic. In March 2020, we had our first positive COVID test. And unfortunately, we only had 100 swabs for a country of 500,000 persons or so. Because of course, a lot of the countries that were manufacturing swabs hoarded them. And it sort of came to light that if we had had saliva sampling at that time, we could have had a better initial response during that first wave to COVID. And we could have saved lives using saliva. So this is very much a part of my interest, that it can also make us more autonomous in the context of being a developing country that doesn't manufacture, viral swabs. The other thing about the Bahamas is that before our independence, our many islands used to be called out islands, but after independence, they became family islands. And so it sort of puts a frame around the way that we are as a developing country coming into our own. And a lot of it has to do with, again, ensuring equity across the space, but also about centering our government programming towards people. It has to be a people-centered access to government services. So in terms of people-centered public health, the WHO has said that the overall vision is that one in which individuals, families, and communities are served by and are able to participate in trusted health systems that meet their needs in humane and holistic ways. And all of this is grounded in universal human rights and dignity, non-discrimination, participation, empowerment, and equity, with a partnership of equals. So as part of this, in terms of public health, we have to realize that this is a partnership between the healthcare provider and the patient, and no less so in the field of diagnostics. All of this has led to me feeling that oral fluids is an excellent way to partner with our patients and our clientele throughout the family of islands. So the reason why I think that oral fluids is a good route to take is because it's non-invasive. It's, at least anecdotally speaking, it seems to be a much more palatable way to take a sample than say taking a blood sample and nasopharyngeal swab. And as this diagram shows here, I know there's a lot of persons here who have gone through this, so I won't go through it in any great detail, but just to say that there's a whole lot of different targets that we can analyze from saliva, which makes it very exciting as a sample type. In terms of the advantages for my tropical climate, it's also, again, we have to get these samples from the family islands to Nassau, the capital. So the fact that it's been shown that saliva can be stable for long periods, particularly for antibody sampling, but also for nucleic acid sampling, at least in the case of SARS-CoV-2. So that's a huge advantage to us, because therefore we need not send it. Some blood samples are required within 24 hours, so it gives us a bigger window for transport and for testing. It's also more cost effective. There's a potential for increased test uptake, particularly in our underserved communities throughout the family islands. There's a low biosafety and infectious risk. These are coming in sometimes on what we call mail boats. So these mail boats are, they're carrying all manner of cargo and personnel. So you don't want highly infectious substances being transported on them. It's also available to persons with a religious or other aversion to venipuncture. And there's minimal training required. People can actually self-sample. The disadvantages are there is a risk of some transmission of, like, for example, tuberculosis. There may be lower sensitivity and a longer window period. And also from a laboratory perspective, there often isn't an availability of quality control panels or confirmatory testing from the saliva itself. The other thing is there's a potential interference by eating, drinking, or smoking. So that's another consideration. Persons have to be instructed on these risks. So over time, just from being a public health diagnostician in the field, I've come to believe that we need to have a holistic look, a holistic grasp of the performance of a particular intervention, diagnostic intervention or assay. So classically, we are trained as diagnosticians that you stay in the lab and you do the test and you see how accurate it is. If assuming, first of all, you make sure the sample is applicable, you ensure that the person is eligible for the test. You would make sure the test is accurate and you perform quality assurance. My realization and argument, the thesis actually of my whole talk here is that we need a more holistic view of diagnostic testing, that it can't stop in the biological domain. It also must go to the behavioral domain, because no matter how accurate your test is, if people don't like it, then they won't use it. And then your intervention has fallen flat. So acceptance and preference in the behavioral domain is a very important aspect, I think. Ensuring even if people find it very acceptable, it also has to be accessible. And what has happened in the past with some tests is that people like it, but it's too expensive. For example, the OraQuick test for HIV. And from there, we hope to increase test uptake because we're dealing in public health. Because we're dealing in public health. And from there, we're gonna link to care. So the linkage to care is actually the most important part of the whole continuum. And my argument is that we need a post-Cartesian perspective on public health diagnostics that is holistic and participatory, again, going back to people-centeredness and partnership with our clientele in order to have effective public health interventions. So going first to the biological domain, we've in particular looked at two cases, HIV and SARS-CoV-2, for using oral fluids. So I'm just going to talk a little bit about, first of all, the biological parameters in terms of the accuracy, the applicability and accuracy of oral testing for those two viruses, SARS-CoV-2 and HIV. And then I'm going to talk a bit about the preference of for them. So in terms of the performance of HIV oral fluids, HIV oral fluids-based antibody testing for HIV, there's been found that there is a pooled sensitivity of about 2% lower than blood-based specimen. This is going back to a big meta-analysis in 2012. However, it matters whether it's a low or high prevalence setting. In a low setting, in a high prevalence setting, it's actually a 9% lower sensitivity versus low prevalence. The other consideration for oral fluids and HIV is that there's a delayed detection, that's delayed window period, and this may pose an issue for high incidence populations. So in terms of applicability of oral fluids for your particular population or individual, it matters whether you exist in a high prevalence or high incidence setting. In the Bahamas, so we actually did a study in the Bahamas looking at the performance of two oral fluids-based rapid HIV tests. And apparently in the Bahamas, where we have a relatively low prevalence, it's under 2%. And in this setting, it was a low incidence because we had an HIV screening clinic, regular HIV screening clinic that we invited individuals to. And we found 100% concordance in 246 persons between the two oral test brands and the finger prick method. So apparently it wasn't relevant in our particular population. The HIV oral fluid seemed to be a very good approach. Now, in terms of the SARS-CoV-2, the global literature has suggested that there is no evidence of a difference in sensitivity between saliva and nasopharyngeal swabs for detection of nucleic acids. But it's of note that the deep throat saliva tends to better correlate with the nasopharyngeal swabs. And this just shows you on the right-hand side just how well correlated it was in this study, Yi et al. 2021. So saliva seems to be very good for SARS-CoV-2 and a bit more nuanced in HIV. Other viruses are less on the ground in terms of the public health practice, but influenza is showing some great promise. That's something that really interests me because, of course, we're all on the edge of our seats about a potential bird flu epidemic, God forbid. HPV and hepatitis ABC have also shown strong performance. Again, going back to the Bahamas, we did a study in our local population, actually in our military. And what we found was that in the samples that were strong, i.e., they were CT value less than 30, there was complete concordance between the saliva and the nasopharyngeal swab, an overall agreement of 95.2%. So going to the behavioral domain now, the acceptability of virological fluids is actually a mixed bag for HIV. For HIV, for example, men consistently actually prefer the blood over oral fluids. Blood-based testing is generally perceived to be more accurate. We found this in our study as well. And this is supported by the scientific data, but it's more painful and difficult to use. On the other hand, oral fluids is considered to be easier to use, but it's less accurate. So information campaigns are needed to relate oral fluids performance and in terms of HIV diagnosis and the nuances thereof. There was a bit of a controversy a little while back. I think it was like in the 1990s where there was a lot of false negatives, and people tend to be aware of that, even if they're not specifically aware of the study. So that's impacted the preference for oral fluids. In terms of the Bahamas, what we found is that so most people actually not most, but of all of the groups between no preference, oral, and finger prick, most people had no preference whatsoever, so they were indifferent. But of those who did have a preference, so these are people who are actually likely to base their decision to come to the clinic on what you are delivering, there was a significantly higher proportion of those persons who preferred the oral testing. There was no effect of age or gender on this, but of those who cited oral fluids as a preference, the 100% of them cited less pain as their reason for the preference. On the other hand, in tandem with the global literature, of those who said that their reason for preference was perceived accuracy, a significant majority preferred the finger prick. So it's a mixed bag. It tends to be a minority of there are persons who have for whom pain really matters, and those would be our target group. So in terms of COVID, saliva is generally preferred. It may increase test uptake. This is from Salzano et al. 2024. And you can see in most regions of the world, saliva or the OP swab or the oral swab, sorry, was preferred. In the Bahamas, similar story. All of those who cited less discomfort as a reason for their preference, again, preferred the oral fluid sampling. So we're looking for persons for whom comfort and pain matters. The oral swab can significantly increase test uptake. To summarize, oral fluids are a sufficiently accurate and acceptable sample type for HIV and SARS-CoV-2, notwithstanding some of the nuances thereof, which going forward into other diseases, I think that we would have to, would bear consideration, because in these two cases, we are dealing with antibody and nucleic acid testing, respectively. So there may be an element of mistrust in some settings that we have to consider that might be impacted by educational campaigns and so on. We do speculate that there may be other psychological barriers to oral fluids implementation. A lot of people feel that, for example, if the medicine doesn't taste bad, it doesn't work. So there's that kind of psychology that has to be overcome, I think, in some persons. But nevertheless, saliva is preferred by the majority of our target populations, and it may be an excellent way, it seems to be an excellent way by which we can target persons for whom pain and discomfort matter. In terms of the future directions, what I'm really excited about, because I personally had COVID twice, but according to tests. You know, I had SARS-CoV-2 twice. I never had COVID. I never actually had a symptom of COVID, although I tested positive twice. And it goes to speak to the fact that COVID is a SARS-CoV-2 is a cofactor for COVID disease. There are other factors that predispose you, given that infection of SARS-CoV-2, to having severe disease. And I think in our classical public health diagnostics, it's disease-centered. So we're looking for the virus, and we're just testing for the virus. But in the future, using a people-centered public health view, what we can do is have a more holistic view of the various biomarkers that can be detected in saliva, such as nutritional profile, immune and inflammatory biomarkers, comorbidities in the saliva omics, and so on and so forth, in addition to the detection of the virus, which will enable us to not only tell you if you have the virus, but we can also tell you your prognosis and perform a risk assessment. We can also plan interventions better and monitor the effect of the interventions. So this is what I'm excited about going forward into the future. And this is a picture of me and my team in front of the reference laboratory. Those are my contact information. And thank you very much for listening. Here's a thank you slide with the Junkanoo, which is the National Festival of the Bahamas. It's very beautiful, and I'll close with that. Thank you.
Transitioning now over to our presenters from Australia, we're going to hear from Dr. Louise Causer and Dr. Tanya Applegate. They're going to be sharing about Australia's First Nations molecular POC testing program for infectious diseases, attributes for successful scale-up and sustainable implementation.
Thank you so much, Brittany. And thank you, Indira, for that beautiful context, providing the challenges of sharing public health approaches in such a diverse community in terms of the geographical locations. I can't imagine how. I want to visit sometime. But today we're just going to be shifting towards the southern part of the world in Australia. So firstly, I'll just introduce myself. My name is Tanya Applegate, and I'll be joined shortly from my friend and colleague, Louise Causer, and we're actually at the Kirby Institute at the University of New South Wales in Sydney, Australia. And we'll be sharing some of our experiences around the First Nations molecular point of care testing program, but very honoured to be doing so on behalf of a large number of amazing people. But firstly, just as you hopefully are already looking at this beautiful artwork that is been designed by Mel Fernando, who's a proud Wiradjuri and Kamilaroi woman from New South Wales and Sydney and part of our team. And Louise will speak to the story of this important artwork that represents our program shortly. So we would like to declare that much of this work is being supported by a research grant from the Australian government with respect to determining how to scale up infectious diseases in remote communities for First Nations people living in Australia. And to this program, SDI have contributed in-kind equipment, including cartridges and platforms. But firstly, I'd like to, both of Louise and myself would very much like to acknowledge the traditional custodians of the lands that we are joining you from today and pay our respects to their elders past and present, and their continuing connection to the skies and the waterways and the land and their culture. So these lands were never ceded, and this always was and always will be Aboriginal land. I'm joining you from Gadigal country in the northern part of Sydney, and Louise is joining you from the lands of Aboriginal people of the Eora Nation in eastern Sydney. So over the next 20 minutes, we'll do very briefly an introduction to the reason why we believe this program is so important, the key principles of the program, and then Louise will be sharing more about the detail and the future directions. So just quickly to set the scene, we, as you may know, we were colonized, Australia was colonized or invaded by the Europeans almost 240 years ago now. And that really has a continuing impact on First Nations people in Australia. As you can imagine, it's a continuous strive to ensure that we have health equity among all of the people living here in Australia. So this week actually marks the end of Reconciliation Week, which acknowledges a report that was released over 28 years ago now, and we're still not doing very well, but the report was titled Bringing Them Home. And this acknowledges sort of the horrifying legacy of the policies of forced removal of Aboriginal children from their families and the stripping them of their connection to country and their culture and their languages. So as you can imagine, this continuing, we are not in an independent country. We are still part of the British Commonwealth. And the stories here just have a small insight into the particular impacts of infectious disease, in particular among First Nations people living in Australia, particularly in remote communities. So very much as Indira was presenting, Australia also has geographical challenges, but to start with, of delivering healthcare, many people think of Australia as it is one continent, but they also think of it as one beautiful country, which it is. But in fact, it has over 500 countries. It is made up of many tribal groups, many laws, and many languages across this vast continent. And for Aboriginal and Torres Strait Islander people, about 20% of them are living in remote and very remote communities, and 45% are living in regional areas. And within our program, as just to set the perspective, the sites that are within our program may on average be about 800 to 900 kilometres from, and that's what we call the crow flies, so directly cross country, to the nearest laboratory services. So as you can imagine, and particularly among this highly mobile community where up to a third of people living in a town may not be in the town at the time, these large distances lead to very long delays in testing results and inequitable access and to affordable testing. So, of course, this has a significant impact on the health and well-being of these communities. So if you think about this in terms of the ongoing impact of the continuing impact of colonization and racism in this country, it is also a complex, other complex factors, including the social determinants of health, that those long distances to labs and hospitals, as I just mentioned, the limited access to healthcare in these communities, resulting in high rates of disease and comorbidities and sequelae as a result. So in terms of infectious disease, obviously the increased rates of and probability of transmission in these settings is something also that needs to be considered. So point of care testing doesn't just provide that sort of improved immediate clinical care and time to result, as we're all very familiar with, but it also provides that opportunity for improved surveillance for infectious disease and antimicrobial stewardship. So the program where Louise will be providing more information on is one program, but it's integrating multiple infectious diseases through molecular testing. And as far as we're aware, this is one of the few examples globally of this sort of program. So it's designed to try and overcome some of the challenges with regards to integrating this sort of service in a remote settings in a decentralized way. As you are all very familiar with, these services are often siloed to disease-specific sort of funding or disease-specific programs. You need to be able to integrate that testing program within the existing pathways, and this is very specific to all the different settings. So we're not talking about, people often think about one community or one setting, but it really does come down to that individual health service needs and ensuring that what do they need and what resources and capacity is there. And as part of this, it's about understanding and overcoming the workforce constraints, delivering services in these decentralized settings. But the benefits are overwhelmingly clear. That's with regards to providing that self-determination for these communities so that they can provide the healthcare services that they need for their communities. It really supports that opportunity for the person-centered holistic care that Indira was just referring to, and it can provide all the more efficiencies with regards to the health service and reduce costs overall. So just to provide, again, context to the settings that we're referring to within this First Nations program, the health services in Aboriginal community-controlled health services, they are a centerpiece of the community and provide a very holistic approach to healthcare. Not necessarily just in terms of what you might think of delivering a point of care test in a service, and that's all it's provided. It provides a whole range of the holistic programs, the holistic care that's grounded in the protocols for the cultural belief systems and community needs. So what we as a team have this shared vision of is being able to build into that existing grounded health service and community service is to be able to deliver a sort of a one-stop point of care shop within that. So in the ideal world, that is definitely community-led. It needs to be community-led, and it very much so is within this program. And in fact, we were very fortunate that the program was awarded for the Shaping Australia, National Shaping Australia Awards, the Community Champions winners this year. So just recognising this program, because of its success is very much because it is community-led. The services will need that dedicated operator to deliver the testing, and it has to be an integrated approach. We can't be just thinking about one infection versus another. The communities have that ability to pick and choose what's suitable for their community and their patients. They have a range to choose from. They're quick to run, and this program is actually able to be decentralized at scale, which is challenging, as you can imagine, in this setting. So again, the point of distinction, I think, is similar to Indira about the behavioral factors that influence uptake. Our approach to this program is very much, it's not a set and forget. It's not a placing a test in a community and walking away. It's providing that holistic sort of wraparound service that builds on these existing strengths. And that it very much includes and must have that Aboriginal and Torres Strait Islander leadership and governance throughout the program. But involved with that is also the clinical microbiology expertise, the research and evaluation, public health and epidemiology information, the quality and management systems throughout, the quality indicators, monitoring those, the IT support, which again is challenging, is often challenging in these situations, and I guess across the large number of jurisdictions in this country, the diagnostic and laboratory support, and of course the logistics, because getting a test to these communities can take, 5 or 6 types of transport and many, many weeks to arrive. So just finally, I'd just like to touch also then on the opportunity that we have building on the experience of this program over the last decade or so, is that we've been able to bring together what we call the point of care building blocks to support the delivery of point of care testing in this person-centered framework. We won't have time to go through the details, but just to touch on these themes, you can see that, as we mentioned, the governance is critical to ensure that the cultural and the leadership is appropriate throughout, and it is led by community. The settings, as we're saying, it's not just one community and one setting. Every single clinic has different needs and perspectives. The stakeholder engagement is a continuous process and is actually probably 90% of the work we do is understanding what the needs are, how they're changing, if things need to be improved. The policies and guidelines are continuously being revised and improved. The risk and quality management, likewise, is a continual process of making sure that the processes that we have in place are continually being adjusted to ensure that you're maximising the care to the patients and minimising any risk. The workforce care and training, again, with a highly mobile workforce with a large turnover of staff, finding ways to ensure that enough people are available and have the competency to be able to deliver this in the services that need them. Connectivity and monitoring, procurement, logistics, as I was saying, are all the important building blocks within this program to ensure a delivery. So I'm actually going to now hand over to Louise, who'll be sharing a little bit more detail about the actual program itself. But hopefully that has set the scene as to why we feel it's absolutely important, this kind of work, and as we continuously strive to find that health equity among all people living in Australia. So thanks, Louise. I'll hand over to you.
Thanks, Tanya. So I'll just now walk you through, I guess, the history and the a little bit more about the scale up of this molecular point of care testing. As Tanya alluded to, we have some beautiful artwork that's been designed and executed by one of our lovely staff, and this work represents the idea of shared purpose and walking together for a common need, which in this case is preventing infectious diseases. We are a very large group. We have lots of stakeholders, and we're very collaborative approach that's underpinned the success of this program. So just turning our minds back about a decade ago or more, this initial concept of introducing molecular point of care testing was part of an initial randomized controlled trial to look at whether there was actually any benefit and feasibility of introducing a sort of moderately complex point of care test into these remote primary care clinics. The focus was sexually transmitted infections, being particular infections that have very disparate rates between remote and urban settings, and in particular, our First Nations communities. As a result of the success of the trial, which indicated that there was reduced time to treatment and that this technology was feasible for use by healthcare workers who were trained and located in these remote settings. The molecular point of care testing approach was scaled up and operationally implemented as a program from 2016 onwards, with a sort of gradual increase in numbers of services. What happened in 2020, as we can all recall, was that the pandemic, I guess, shifted priorities. And in our remote communities, not only do they have disparate rates of STIs, but also sort of comorbidities and other vulnerabilities that make these communities particularly vulnerable to the sequelae of COVID-19. So as part of the response, and because we had a network and infrastructure of molecular point of care testing platforms, and there was a newly available cartridge that could detect SARS-CoV-2, our program was tasked with pivoting and scaling up further to allow for community-led PCR testing for SARS-CoV-2. That transitioned actually into a respiratory panel with the 4-plex that's available, which covers SARS-CoV-2, flu A, flu B, and RSV. That was in 2022. And now we operate as a fully integrated program, being able to offer 3 STIs, chlamydia, gono, and trichomonas, and 4 respiratory infections. So over the decade, we were able to scale up from a small randomized control trial into a large decentralized molecular point of care testing network. And that network is now known as the First Nations Molecular Point of Care Testing Program. So point of care testing in these settings is integrated into routine workflows in the primary care health service. For STIs, this might be routine opportunistic screening where somebody comes in, they're asymptomatic. They may self-collect or have a clinician collected genitourinary specimen, and then the trained operators perform the test while the patient is waiting. Sometimes this might be as part of an annual community screen, which occur in some settings, in some of our remote settings. For respiratory infections, it's often more prompted by a presentation at a health service with symptoms, and there may or may not be use of lateral flow respiratory antigen testing in advance of a molecular point of care test. There are some examples of outreach and mobile models. However, most of the testing and the collection of specimens is occurring at the health service with clients presenting in the first instance. We use existing clinical staff who are trained as the test operators, and these are generally Aboriginal health workers or practitioners and nurses and doctors. And as Tanya mentioned, there is a fully functional connectivity system that supports this integration, with results being aligned with the way centralized laboratory results would be returned to health service, which is digital and integrated into an electronic health record for patients. Tanya mentioned the importance of governance in our program, and this is very much front and centre of the program. We have a First Nations point of care law and governance group who ensure the cultural safety of implementation and resources and training. We have regular engagement with our jurisdictional, our state and territory stakeholders to ensure that priorities are identified, and we are also very aware of any barriers or facilitators to implementation. There's a very robust quality management system that includes external quality assurance being performed 2 to 3 times per year, and monthly quality control specimens that are sent out to health services to do on a monthly basis. We have a large array of training and resources that have been developed. Training is delivered, used to be delivered entirely face-to-face, but as a result of COVID, we've had to diversify our methods, and we offer an online and a self-paced module training approach. The training includes both a theory and a practical competency assessment. And once somebody is deemed competent, their competency is valid for 1 year. The connectivity and reporting allows us to provide results in real time for clinical management, and results are also used for public health surveillance, particularly in the case for notifiable infections. And then we centrally are able to monitor testing for purposes of program implementation. So this is just a quick snapshot of where we're up to at the moment. So we have locations in regional, remote and very remote Australia offering a suite of tests. We have 96 individual clinics currently enrolled, and at our peak during the COVID pandemic, there are 126. 65% of the clinics offer both respiratory and STI testing. The respiratory testing is offered at some clinics solely, and the same for STI. Over the period of time that we've been operational, more than 60,000 STI tests and more than 80,000 respiratory tests have been performed. Significant numbers of health professionals have been trained, and Tanya alluded to some sort of relatively high turnover of staff in these remote communities, which makes training and keeping on top of having competent operators in community a bit of a challenge. For our respiratory testing during the COVID pandemic, we needed to introduce some extra precautions to minimise contamination that could be associated with PCR products. And we're also currently embarking upon a national accreditation of the program. And just some quick evaluations that have been done of the programs, both the STI and the respiratory, just showing the benefit of a programmatically implemented molecular point of care testing program. There has continued to be, beyond the trial that was done 10 years ago, increased proportions of people tested and cured in a more timely manner. And in fact, as the alternative is a centrally based laboratory test, what we've been able to identify is that the median time to treatment has been reduced for diagnosis of chlamydia and gonorrhea by 10 days in these settings, and for trichomoniasis by 25 days, allowing earlier treatment and reduction of ongoing transmission in community. And with fewer onward transmissions, there are fewer sequelae, particularly pelvic inflammatory disease and poor birth outcomes that are associated with STIs. Of interest perhaps to the audience might also be that in the hands of these trained healthcare workers, our concordance with laboratory-based testing is very, very high. Our overall unsuccessful rate out in community is about 2%. And many of those unsuccessful tests are often related to operator or device error. And these are all routinely investigated by our team, and additional training is offered if needed, or a repair and replace of a device if needed. What we do recommend, and we find is usually adhered to, is that most of those unsuccessful tests are repeated and then return a valid result. And this is usually done immediately after, when an operator sees that they've got an invalid or an unsuccessful result. For the respiratory program, there was an independent evaluation during the pandemic period, which in fact showed that up to 120,000 infections were averted as a result of the implementation of molecular point of care testing in community, and that also there were some significant economic savings, which all boded very nicely for the continued funding of this program beyond the significant part of the pandemic. So just thinking about the context of how to sustain a program, we obviously had some very clear success from a randomized control trial, and then an excellent outcomes as a result of a program evaluation showing the benefits of STI point of care testing. So it was clinically effective, very accurate, reduced community transmission. We were able to sustain the scale up and increase testing over a 7-year period. We've also got lots of qualitative evidence to suggest that this approach is actually acceptable not only to clients but also to the clinicians who are performing the testing, and very importantly that the program is cost saving and cost effective. Some modelling has also been able to demonstrate those reductions in sequelae, reproductive and birth outcome sequelae that have been really important. And as a result of all this evidence, that's actually culminated in some changes to policy and practice, including we've got now STI point of care testing included in national and jurisdictional guidelines. It's also included now as part of our notifiable infections case definitions. As a result of those changes, there's also been renewed funding from the Commonwealth to continue this program. And most recently, there's been a new publicly funded rebate for the testing in community, whereby health services can claim a rebate to cover the cost of their consumables and also for the staff time required to do the testing. So over a decade, there's been the collection of evidence and the stakeholder engagement and advocacy for this larger program to continue, and we hope continue into the future. Some next steps that are on the cards for the coming year or years. We have a number of demonstration projects, so using the same molecular-based platform, but introducing some other assays for priority infections in these same communities. One is Group A strep for the prevention of acute rheumatic fever and rheumatic heart disease, and the other is around human papillomavirus detection as part of the prevention of cervical cancer. And both of these, as I mentioned, are priority infections and have disproportionate impact and burden on these communities. The other piece of work that we're looking to progress is looking at a way to address the workforce challenges. I mentioned that we currently train clinicians, and our next task is to look at the benefits and quality and feasibility of training non-clinicians in these settings. So community workers who are sort of part and parcel of the community and tend to stay in community longer, however, don't have that clinical background. So this is a new area that we're looking at that has been identified both by stakeholders and by the program. So that and we're going to do our initial piloting of that work within the Group A strep project that's just gotten started this week. And maybe just finally to say that I guess to make a program like this sustainable, we need more than just research. We need to have sustainable funding. We need to have healthcare plans that support the implementation and recognise the benefits of point of care testing. We need to have point of care testing and ways of, I guess, improving the regulatory framework by which new assays and new promising tests, as they become available, are more rapidly able to be integrated into these settings. Clinical guidelines and strategies all need to be able to be updated quickly to ensure that everybody's on the same page about the value and use of these technologies. And finally, just to say, here are our contact details if anybody in the audience would like to reach out further and hear any details. And if you hadn't already heard, there's another conference later this month in Bangkok, and there'll be lots more talk about point of care testing at that conference. Thank you very much.
Thank you so much, Dr. Causer and Dr. Applegate. Really appreciate you both sharing with us information about your work and what's going on. And I certainly have lots of questions noted down that I'm excited to ask when we get around to that. We do have one more presentation coming up, and that is from Mara Aspinall, who's going to be joining us to share about transforming healthcare, the power and potential of testing.
Hello, my name is Mara Aspinall, and I'm very pleased to be here to present the power and potential of diagnostics and how diagnostics and testing is indeed transforming healthcare. I'm a partner at Illumina Ventures and editor of Sensitive and Specific, the testing newsletter. Let me first share with you my disclosures and the additional board of director positions, as you can see on the slide here. So with that, today I'm going to talk about 5 different topics. I'm going to start with the fundamentals of testing, talk about the history of testing, particularly home testing, and then a fundamental shift in healthcare. What is the role of alternative samples, such as saliva? And then what does the future hold? So with that, let me start with talking about diagnostics. And in many ways, it's the wrong name for our industry because diagnostics are so much more than diagnosis. Today, and our panel is really talking about the importance of the patient journey. So let me start with that patient journey and say it's not just about diagnosis. It's about 6 different pieces of that patient journey. It starts with screening, the average risk population. It then moves to early detection, typically those with high risk. Then it's focused on diagnosis, then prognosis, how serious is it? Therapy choice, and what's often overlooked, the importance of testing for treatment. Is the treatment working? So those are the 6 questions that patients ask. But what is the question we need to ask as an industry? And I'm going to be maybe controversial here to say, should we be known as the testing industry? And we are so much more than just diagnosis. That being said, I'm going to use testing going forward, but I'm going to give you the context and a little bit of the history. So we're going to start with the history of testing in diabetes. And this is something that hundreds, not even thousands of years ago, people were diagnosed with a disease called sugar disease or diagnosis. And how was that done? It was done by somebody tasting the urine, not chugging it, but tasting a small amount of it or even smelling it to say, it smells and tastes like sugar. We then moved on to the contemporary, not so contemporary, 60 plus years ago, the urine test strip. And then for most of our lives, the blood glucose meter. And today, much more common is the continuous glucose meter or CGM. So that gives you a sense of diabetes over time. But why is that so important? Because I would argue diabetes shows a fundamental change in approach for diagnostics. The past was all about having one data point and making it as accurate as possible. Today, it's not just that one data point, it's multiple data points and making the trend as accurate as possible. But what does the future look like? In my mind, the future is continuous monitoring, the diagnostic data plus drugs plus AI. And what does that look like for diabetes? Something like the contact lens glucose meter. It's not just once a month, once a day, or 5 times a day. It's 500 times a minute. That's what the future is. Whether it's indeed a contact lens or something similar, I don't know, but it's continuous monitoring. And then it translates directly into delivery of the therapeutics. Where does AI come in? Well, often the data is not perfect from any type of diagnostics. And what AI can do is train on an individual person or their digital twin and add the data that's missing to make an accurate assessment of what type of insulin in this case or other drugs are necessary. So that's the change of approach, not about one data point, but about many, many, many data points. But where did this start? So I'm going to talk about the history of home testing and self-collection, part 1. And part 1, well, we'll forget about the 4th century and Hippocrates looking at urine, but really starts almost 70 years ago. And it's all about diabetes again. One of the first tests at home were urine dipsticks. We just saw a picture of them. They were looking at glucose. Then we had blood pressure monitors. And then a huge step forward was the pregnancy test through urine. Quite controversial, actually. We see the blood stick, the finger stick blood with those blood glucose monitors, the original ones, and a number of different tests, including cholesterol and strep A, that frankly did not take off and were only available for a short period of time. But the 1900s ended with oximeters getting at home. We know were used a lot for COVID, but we'll get there. And then the FOBT and the FIT test with feces. So you see a number of different innovations in home testing and self-collection. But when did it really change? By the year 2000. Here is, we already see dozens of different types of home testing and self-collection. It started with INR testing, never done at home. And then we know the revolution started by 23andMe with saliva or cheek swabs to do DTC genomics. And it continued with devices, whether they be Fitbit or Apple Watches, at-home HbA1c test, again, for glucose. And then you could see over this period of time how it has changed. When was saliva used? We talked about DTC genomics, then home HIV tests, and then we know it changed tremendously with COVID, when we had saliva or nasal swabs, and again, continuing with COVID for saliva or nasal swabs with combined flu A and B plus COVID. This has been a true revolution. When you look at this chart, the ones with a white background are fully home tests. You can get the data and the answer at home. The ones with a purple background are home collection. And then the collected sample is sent into a central lab of some sort to get an answer. So this has been a tremendous revolution, and saliva, and as you'll see, other samples are a core to it. But where did this really explode? You know what it is. It's in COVID. So let's look very quickly at the history of COVID testing. It starts out with symptomatic diagnosis and moves to active disease screening and surveillance. And much of surveillance now is happening with wastewater. Where were these tests being done? It starts in hospitals, central lab, point of care, and now home and point of need. But the important part is, where were we sampling? It started with lungs. It went to those NPS swabs, you remember, tickle the brain, then minimally invasive, just the front of the nose, and ultimately non-invasive. Yes, there was a moment there where we looked at, could breath be useful for COVID? And while it might be in the labs, it never really took off as sensitive and specific as it needs to be. But saliva played a critical role on a public health basis, as well as individual tests. And what's the cost? We always have to look at the money. It goes from thousands of dollars to hundreds of dollars to tens of dollars to just, on average, less than $5. And I think that the cost of a COVID test alone will continue to decrease over time. So that's the history. But where does this testing happen? For a long time, as we talked about, it was all in the central labs, and now doctors, outpatient clinic, and homes, it's in the point of need. So why is that so important? Well, I'm going to talk about my third area, is the fundamental shift in healthcare. And that shift is where the testing is being done and moving to the home and lower cost settings. And why is that happening? First, I'm going to talk about the explosion of chronic disease. So I look at those chronic diseases. Can I give you some data here? Well, first of all, the good news. The death rate from chronic disease just in the last 25 years has plummeted. It's gone down and down and down, and that is great news. But what's the challenge? The challenge is the healthcare costs for treating those diseases have gone up. And partly on an individual basis, it's gone up, but we're treating people happily, should be happy, for many, many more years than we ever did before. Heart disease, diabetes, neurological diseases are all of those that, while we can't always cure them, we can treat the symptoms much more effectively than we ever could. So that's the overall piece of the healthcare costs for chronic diseases. But what else is happening? Let's look at 4 other key drivers. Number 1, decentralization of care into lower cost settings. There's lots of data here, but I'm just going to show you one chart that really, it's not only about costs, it's the fact that the total number of beds in the US is going down. You look at that chart and you look at the 0 at the bottom and say it hasn't changed all that much. Well, about just over 1% a year. But what's the population that is most likely to go into that hospital? They're increasing at 3% a year. And we just talked about chronic diseases. While many of these people did not survive into an elderly state, they're now spending more and more time in the hospital being treated for these diseases. So there are fewer and fewer beds available. What's the next issue? Patient agency. And we're at a time that there's a lot of controversy in our country about how to handle healthcare. But I'm going to say that lots of people on every side of the political spectrum appreciate the importance of patient agency. And what do I mean by that? If you look at healthcare and ask people in a wide variety of settings, what do they want and how do they perceive their healthcare? Well, the number one area is they want to manage more of their own healthcare at home. And half of them say they can't get what they want when they need it. So it's all about control, and people want to take back control into their own lives. And what's the number one area of healthcare services that people are on average most comfortable with at home? What is it? Almost 60% want to have at-home test kits with instant results. They want to take control back. Interestingly, number 2 is also about being at home, and number 3 as well, telemedicine and virtual appointments, and number 3 is medication home delivery. So it's all about bringing these services at home. Third area, skilled labor. Well, that sounds good. Well, if we have lots of people, can we just treat them in hospitals? You just saw there are fewer beds in hospitals, and I'm going to say there are fewer people to help, whether it's in hospitals or doctors' offices. We can look at this in a number of different ways. One is kind of good news. Healthcare employment needs continue to grow. Number 1, healthcare support, 15%. Number 3, healthcare practitioners and technical people. But the gap between the openings and the hires just continues to explode. There are far more openings than there have been hires. Now, why is that? There are lots of reasons that we could debate, but what I'm confident of is that the US will face a shortage of people in every dimension here. And they will face a shortage, we will face a shortage of home health aides, of nursing, of lab technicians, and many of you in the lab industry very much know this is true. And it's not only in the US, it's true globally. The global health workforce shortage is critical now and only going to get worse by 2030, which is only 5 years away. So that's issue number 3. And issue number 4, and the one that it's both great news and bad news, but mostly great news. It's technology and business model advantages. What do I mean by that? Number 1, treatments are getting better and easier and can be given at home. Number 2, diagnostic technologies are better, simpler, faster, and cheaper, with little to no sacrifice in accuracy. That's what we need. And number 3, what brings it all together? The digital connectivity that enables these integrated solutions. So let me share here. First, there's not a lot of discussion about this, but it is so important that healthcare is shifting to home. It started with hormone injections for in vitro fertilization and back to diabetes and insulin. So those existed, many, many years ago. But it was only since 2009 that so many chronic diseases, psoriasis, Crohn's, neutropenia, that's not so much a chronic disease, but happens with chemotherapy, GLP-1s, which they're popular now, but they actually existed as pens in 2015. So many of these chronic diseases, including migraine, one that means a lot to me, arthritis and otherwise, can now be given at home. And with more and more people comfortable with drugs at home, it's going to make it easier and more affordable and more reasonable to do testing at home. When I look at testing at home, I've talked about this a lot. I call it less invasive samples, but it's important to look at them in 3 categories, all with the letter E: established, emerging, and experimental. So on the top line, you'll see sample types that are well established from blood, eyes, in alphabetical order, and clearly saliva. but we see more and more tests being done on emerging areas like breath and gait and interstitial fluid, seminal fluid, menstrual blood. There was an approval you'll see later, and even, excuse my voice and scratchiness today, voice. And then really exciting, what is the experimental treatments we can do in the future? How can we learn from hair? How can we take a picture of nail beds to look for anemia? I think we will see many, many more exciting innovations in these less invasive and easier to use for consumers and also easier to use for physicians. Has the FDA recognized this? Well, 2024 was a banner year. I've talked a little bit about the flu, COVID home tests, the first menstrual blood home collection, the first over-the-counter glucose meter, so you don't even need to have diabetes to understand how your glucose changes, the first home syphilis test, and then additional tests that are all about the point of care, including even very recently, new blood tests for Alzheimer's. Most of them have been LDTs till recently, and in 2025, we had a new test approved as an IVD. So the FDA has really looked at the importance of this and granted many approvals for these new diagnostics in 2024. So where does that put us? So I'm going to have my last section here talk about a model for testing. And I'm going to start with what I call testing 1.0, 250 years ago. The question was, is there disease? 50 years ago, what disease? Today, what subtype of disease? Because it's very personalized. In the future, it's all about, can we identify risk? And indeed, testing 5.0 is, can we preempt disease? What are the tools that we're going to use? Testing 1.0 was just the doctor's 5 senses: nose, eyes, mouth, hands. 50 years ago, it was just manual testing systems. Today, it's virtually all automated. But what does the future look like? And we're really starting to be there today. It includes data analytics, and testing 5.0 is diagnostics, therapeutics, and AI. And when I talk about those data analytics, what do I include in there? As I just talked about, alternative samples, including saliva, and so many more. So testing 5.0 are those key questions, but I think what's most important is it's fully integrated with data, whether that be patient history or imaging or clinical trial or genomic data, or just the point of care test that we've talked about, whether at home or elsewhere. But the key is an integrated summary of all that data, not just in the doctor's brain, but I believe that we'll have the emergence of a data interpreter. And what does that data interpreter mean? Well, the real question is it a person? Is it a machine? By machine, is it software? Is it the physician, or is it the patient themselves? We will see, but I believe that testing 5.0 will be here very soon. So as we look forward, what do I see? 2024, we've talked about what's in 2025 and beyond. First, I think we will see diagnostics get much more sophisticated in markets beyond oncology. We've all in the industry talked a lot about oncology as being the first place with personalized medicine. We will see it in CNS disease, as I've talked about earlier. It's already beginning in neurodegenerative disease, particularly Alzheimer's. We will see it in many more autoimmune diseases, which is a key area to use proteomics. And then lastly, I think we will see innovation in metabolic and cardiovascular, not just about GLP-1s, but focusing on MASH as well as the best use of GLP-1s. So that's on the market side, but now let's look at the technology. 3 areas here. One is digital pathology is finally here. I've worked in this industry a long time. We've talked about it for years and years. It is finally here, and it has passed the tipping point. We will see dramatic increases in the use of digital pathology. Next, diagnostics for drugs, truly seeing companions used, monitoring for not just companion diagnostics, but true monitoring going forward. And it's not new to diagnostics, but AI will be used on the clinical, operational front, as well as test development. AI will be ubiquitous. So as I conclude, let me just say, I believe for the rest of this conference, we need to be talking about 5 key questions. Number 1, education. Who trains healthcare professionals on this next generation of testing? Number 2, education for consumers. Who gives consumers accurate information with so much misinformation out there and the risk of it? How does that happen? Number 3, it's always about follow the money. How will payers be reimbursed for testing? And will home testing be different from testing in the doctor's office or testing in a central lab? Who will invest in testing with these alternative samples? Research is core to our industry and is important to move forward. And then lastly, as I've talked about AI, how can AI improve testing? So I hope in the rest of our discussion today and for the rest of this conference, you keep these questions in mind so we have very clear answers as we gather again next year. So as I mentioned, Mara Aspinall, please feel free to be in touch or subscribe to the newsletter. It's free on Substack, and very much enjoyed the opportunity to work with you today, and hope we keep in touch. Thank you.
Our thanks to Professor Aspinall for sharing that message with us. The first one that I saw came through was, what is your suggestion? And this is for the whole group. I would say, what is your top suggestion, or maybe 2, for how testing programs can do a better job of incorporating local cultural perspectives into testing programs? So bringing those technologies like Mara mentioned in her talk just now out to market, or finding ways to incorporate local traditional perspectives. What's your top bit of advice or suggestion from your experiences? Dr. Martin, would you mind going first?
Sure. So again, I think this is a very key part of implementing any kind of test modality. Ideally, what I would love to see, going into the era of AI and so on, I would love to see that feedback from the community actually be integrated into the total picture of the test effectiveness. So not only are you gathering information about how well the test performs, but also you have sort of fingertips out into the community that are assessing, biocultural aspects of the implementation. And so a much more non-reductionist approach to implementation of testing. That would be my recommendation.
Thank you for that. Dr. Applegate, Dr. Causer?
Would you like to go ahead, Louise? Okay. So I very much in reflecting Indira's perspective there, it is about the genuine inclusion of the affected communities from 10 years prior to when the test becomes available, or the idea is born, or it's really to understand that need from day 0, be embedded within the community. So having members of the community participate in really understanding what those needs are, those priorities are, but it has to be, it's similar to the concept of that ongoing stakeholder conversation. It's a continuous conversation, but their involvement is central to the development of any test and implementation of any test through to that large scale up and routine delivery. Otherwise, as Indira was saying before, it just fails. A test that's not used. And it could be the tiniest little thing that someone in a lab's gone, oh, this seems fine. But actually, it's not fine when you put it out in the community. And why would you do it that way? So yes, those conversations need to start a gazillion years ago and need to continue throughout the pathway.
I think if I can add, in our program, we have a very open communication, both with the sort of end user, the clinicians and the health service, and a team within the program. So it's two-way. It's not sort of a one-way delivery, but in fact, the health service and clinicians can contact our team through what we call a help desk, by email, by phone. It's, business hours, Monday to Friday. During COVID, it was, we had another component that was 24/7 online. We were available. Tanya and I staffed that across the entire country. It was kind of phenomenal. So the relationships that were developed and the trust kind of actually grew significantly during COVID because everybody was on, you know, like everybody wanted to do the right thing, the best thing. We wanted to protect the health of our entire population, but particularly these communities. So it's interesting, you know, despite the hideousness of the pandemic, those relationships were so much strengthened. And I think the other thing for our program over this sort of decade of gradual scale up, you know, things have been optimized on the way with feedback from communities. So we've probably ended up with a program that's catering to most. It's flexible at the health service level. Like we don't dictate how it's to be used, but in fact, it's incorporated into the workflow. It's part of usual practice and usual kind of delivery of services. And if somebody, you know, if a service chooses not to use it, it's okay. You can give it back. Like it's, you know, it's not sort of, flexibility, I guess, has been really important to ensure that all those behavioural aspects which make the test beneficial kind of come into play there in the right way. Yeah.
Absolutely. That importance of being flexible and responsive and incorporating community perspectives from the very early stages in that program design and doing what we call iterative engagement in our team, where you're constantly engaging and seeking feedback and making sure you're not losing that loop in that cycle. Thank you. Yeah. There's a question that came through that's specifically for the team out in Australia, and that's if you've been able to integrate AI into your point of care testing program, and if so, what has been the experience so far?
So I think my understanding, Louise, you can correct me if I'm wrong, that we actually don't use AI in our current format, but there are considerations, for example, in of tools in training, for example, we're thinking about, because as you can imagine, the being able to participate in person in these remote communities for training competency and managing any sort of questions that people have in person, that using virtual reality is one thing that we've been thinking about. But again, whether this is something that is really needed, wanted, is being explored at the moment. But Louise, as the IT expert in our program, I'll hand over to you for the use of AI in our program.
Yes, agree. We don't really use it, but there's interest. And we've got a couple of people in our team who are sort of trying to run with this and making significant suggestions about how we might, whether it's from us in terms of just, you know, at the back end, kind of improving our efficiencies and streamlining our processes around logistics and so forth, or whether it's something that's a bit more front facing, yet to be kind of progressed. But there is an interest, and I think if this is where we're heading, which it seems, let's embrace it. We need to get a few other skill sets in our team probably to bring that up to speed.
Fair. Very fair, very fair. One question that came through when Dr. Martin was presenting, but certainly can be opened up, is would you mind speaking to the impact and the importance of including community health workers in programming, perhaps in introducing these technologies, or maybe you can find someone who's amazing in IT out and who knows where, but would you mind speaking to the impact of community health workers and training them and bringing them into the process?
Sure. So certainly, again, going back to our archipelagic situation, we lean heavily on our community health workers on these islands. It ends up being a head nurse often, because there's often a physician travels to the island, but sometimes, especially on less inhabited islands, there's actually no physician there. So you can imagine the head nurse, she lives in a house in these small rural settings, and anyone who has a sniffle, they're knocking on a window at 3 o'clock in the morning. So it's a full-time 24-hour job, and these nurses are the phlebotomists. They are sometimes they're the transport officers for the sample transportation. So we lean extremely heavily on them, and it's important to have a lot of cross training with them. And it's also important to dialogue with them, because no one understands the health milieu on their particular island better than these head nurses and their staff. So it's very critical. And right now, actually, what we're doing, for example, is training them in biosafety, which is something that is not directly pertaining to their role, but you know, on these islands that are isolated, you have to ensure that because samples are being taken, that they're being taken in a way that is safe for the community, given the lack of resources. So.
Louise, would you like to comment on the community liaison health worker operator
Yes.
program?
Indira, there seems so many similarities in terms of that level of health service. So if I can say, many of the remote communities maybe have a live-in nurse, a fly-in, fly-out doctor, and then they may have Aboriginal health workers or practitioners. So these are First Nations staff who have had clinical training. They're likely to be located and live in community and very connected community. They may be from the community. So there is this sort of connection with community where they understand the community and can facilitate, I guess, the integration of point of care testing. All of those workers, however, do get pulled and move out of community. And this is one of the biggest challenges for us in maintaining our programmatic delivery of molecular point of care. So our next sort of, I guess, foray is going to be looking at non-clinical staff who would probably be equivalent to community liaison officers or community health officers. So they might be employed by the health service, but they might be the driver. They might be somebody else who's not doing clinical tasks. One of the challenges, I guess, is understanding what potential other upskilling they might need to make them feel comfortable and confident to go forward and do some additional training that would then give them the skills to be kind of the point of care point person. So they might actually take on responsibilities not only for the testing, but for the maintenance of the device. They might be involved in logistics. It's sort of an interest, and this is coming from the communities where they're saying our staff, so the nurses or the other clinicians, just do not have the time because they're attending to emergencies, chronic health disease, to step away, run a test, come back. You know, it's about using the workforce in the most efficient way, and also giving and empowering the staff at the health service opportunity to upskill potentially. I mean, big picture could be a potential career path too. I mean, if you can imagine sort of a growing suite of point of care testing, a whole different range of platforms. It could be simple lateral flows, or it could be these more moderately complex, but still potentially more rapid molecular tests that are sort of in the pipeline. It could be a whole role for an individual. So we've got some very interested services who we've got good relationships with, and that's going to be something over the next 6 to 12 months that we'll be embarking on. And I guess the context is Australia, where the regulation to be able to do these is also really important. Funding is tied to certain job responsibilities. So there'll be a little bit of work, if we find that things go well, to then kind of say, okay, well, these people, you know, are eligible. We've shown that they can do the test. It's accurate. We're getting more testing because of an increased workforce capacity and longevity. Yeah, I think it's a really exciting. I mean, there are obviously examples internationally of where that can happen. So yes, everything's pointing towards enhancing the workforce that's able to deliver point of care testing.
Absolutely. Absolutely. And a common theme that I'm hearing from both of the responses you offered is having that trust, having someone that's in the area, having someone that is recognized by the community, and then also meeting that response, being responsive to what you're hearing. It's that iterative engagement process where you're hearing that this is a need, and then you're not asking your local healthcare worker to take on yet another responsibility where they're really going to have their windows and doors knocked on at all hours of the day if they have to, you know, get the equipment up and running. Dr. Applegate, was there anything you wanted to add to that question?
No, absolutely no. I just the only comment is that trust is the classic line that my son said to me the other day is it's a forever project, and so that is that continual relationship building and that continual trust, and that makes this all possible. So
yes, that forever project. That's a really beautiful way of phrasing it. I think we've got time for just one more question. Let me check it and see what we've got over on the list. I would just ask, maybe just like a quick response from each of you would be, where do you anticipate the biggest return on investment in developing care in community settings? Where do you see, whether it's a a diagnostic that you think could really be helpful, or a type of testing modality? What are you particularly excited about? What are you seeing is coming down the pipeline that would be really impactful for community settings? Dr. Martin, maybe you can go first.
Yeah, so again, it's going back to our philosopher from the Caribbean, Edouard Glissant, speaking about everywhere being in the world being an archipelago. There's definitely a lot of commonalities that I'm seeing, which is really enlightening with this massive landmass, which is the opposite of the Bahamas, being Australia. So it's very interesting to see that. And following onto that, what I'm kind of hearing and what I was thinking just now, in terms and speaking to the return on investment as well, is re-envisioning the role of the lab and the structure of the lab, especially in light of these public health threats, because we're living in this like epidemic reality. It feels like every other day there's a new virus, you know. So yeah, I think the best and most exciting thing for me is going back to this concept of equity. How can we take funds and ensure that they are equitably distributed across these disparate spaces? And we spoke to strengthening our sort of finger or hands in these local communities. When I say hands, I mean like healthcare workers that might not be lab professionals, but training them, putting investment into that to train them to be part of this re-envisioned lab system. And also, I think just having more data, you know, like an investment in data, getting data, analyzing data, and having smart responses to whatever the epidemic, MILU, or the medical landscape is in our settings. I think that would be the most exciting part from a systems perspective.
Absolutely, that would be very exciting. Dr. Causer or Dr. Applegate, do you have a quick 1 minute thought that you might offer?
I think the only additional thought to, again, supporting Indira's comments just then, is new tools to think about that. So sometimes people think, oh, return on investment sort of from a traditional approach, or cost effectiveness from a traditional approach. But making sure that people think about that from a very holistic perspective. It's not just the pathology test versus a point of care test, and that's where it ends. Is thinking about all the long-term impacts and on the community and the public health going forward 5-10 years. But even then, it's not just cost effectiveness in its traditional sense. It's how there's a new tool with not new, but something that's very important and people are considering more and more, is that distributional cost effectiveness. So it's not just about actually getting bang for your buck, but are you getting that social determinants return effectively where the impact is most required? Not just, yeah, it costs this and you get this return. It's actually you're getting the return in the right places for the right people for the right reason. And that needs to be considered in that holistic way. And as Indira was saying, the data sharing to allow you to do that, the evidence generation to allow you to bring all that together to make those really informed decisions about really truly where that return on investment is required and where it should go.
Absolutely. And all of that investment and being aware of where the data is coming from and going feeds into that trust being a forever moment. It becomes a forever opportunity, right? Well, thank you all for joining us. I really, really appreciate a huge thanks to our speakers who have joined us, Dr. Martin, Dr. Causer, Dr. Applegate, as well as Professor Aspinall, who sent through their video. So thank you all for joining us today. And again, thank you to our speakers. Really appreciate your insights offered.
Thanks very much.